During the shoulder arthroscopy, we are looking from the posterior portal with our camera towards the rotator interval where the anterior portal will be placed. Once the cannula and shaver are introduced, we can better see the subscapularis tendon below, the supraspinatus tendon above, and the labrum or tissue that surrounds the glenoid socket. Also note the biceps tendon that runs from the superior labrum just below the supraspinatus. The shaver is sitting above it in this shot. A tear in the rotator cuff supraspinatus tendon insertion appears to be full thickness. This is debrided using an arthroscopic shaver and an electrocautery device that applies heat on a low setting. Now we're in the subacromial space where we perform a synovectomy and bursectomy in order to better visualize the rotator cuff that we noted in the articular space. The undersurface of the tendon is prepared using an elevator and a burr to achieve bleeding bone to help with the healing process once the tendon is secured back to the greater tuberosity. Arthroscopic sutures are then placed through the tendon to secure it to an anchor that will be positioned on the lateral aspect of the humeral head. And all is used to prepare our starting hole to accept the anchor once the sutures are passed through it. This particular anchor is made of a biocomposite material which eventually gets resorbed into the bone once the tendon has fully healed. Suture limbs are then cut, and then we check our repair from the lateral portal.
The manual technique being utilized here by the physical therapist is known as a joint mobilization, typically done in a grade 1 or grade 2 fashion immediately following post-op to help decrease pain throughout the joint by stimulating the mechanoreceptors. This ensures that the therapist can take the patient through a deeper passive range to help increase their overall range of motion in the shoulder joint. If done properly, the therapist will get the patient past the range that they are normally comfortable with immediately following, and will allow them to go through their rehab process on their own and get more out of their passive range of motion. Next, the therapist takes the patient through passive range of motion into flexion by guiding the shoulder through the range, cupping the shoulder girdle to help make sure that we ensure good contact. Afterward, the therapist takes the patient through abduction, the two main planes that are essential to regain as quick as possible immediately following surgery. Codmans, or pendulum exercises, as seen here, are essential immediately post-op to help decrease pain for the patient. They also help decrease joint stiffness, they prevent adhesions and contractures, as well as increase circulation and improve healing throughout the rehab process. This exercise is usually one of the first ones done to help passive range exercises be less painful. The pulleys exercise shown here is typically used immediately post-op to help regain passive range of motion in the flexion plane, which will help the patient be able to reach overhead in later phases of rehabilitation. Cane abduction, as seen here, is often used early in the rehab process to help regain passive range of motion in the abduction plane. Passive range of motion and external rotation is usually done somewhat later in the rehab process in order to help regain range of motion in external rotation. This is usually dependent on the rehab protocol set forth by the surgeon based on what he saw during the operation. Early isometric loading, as seen here, of the rotator cuff immediately following post-op in recent research has shown better function and less maximal pain throughout the rehabilitation process. Towel slides or table wipes, as shown here, are an active assistive range of motion exercise typically implemented somewhat later in the rehabilitation process, somewhere around weeks 3 or 4, to help get the patient ready for the actual active range of motion protocol. This helps load the muscles and the joint to ensure that they are ready for movement against gravity.